Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited, customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
You don't realize how difficult it is for people to access healthcare, and it's really hard for people. There are so many people that come to us and say that they don't have the money to have the procedure done, and to be able to make that happen when they otherwise wouldn't have been able to if WellBridge wasn't here, that's just really, really neat. And so there's some that even still can't do it because they can't even afford us. We don't get everybody, but we get enough people. That's pretty cool. I am Dr. Eric Inman, and this is my direct surgical story.
Dr. Eric Inman is an Indianapolis native who graduated from Indiana University Medical School in 2006 and is a practicing anesthesiologist on the north side of Indianapolis. The need for transparency in the healthcare payment system and his strong drive to effect positive change in surgical care were the impetus behind his co-founding of WellBridge Surgical. He is passionate about providing a high-quality, fair-priced option that empowers patients to become active healthcare consumers. Welcome to the podcast, Dr. Inman.
Thank you so much. I appreciate it. It's exciting.
For years, I've been wanting to have your story and Dr. Smith's story on the podcast. And so we're checking that off already, and we're only mid-season. But this is so fantastic to talk with you because there are so many people who are scared about what's happening to insurance with premiums, employers, self-employed, and people are looking for different options. Now, saying that, I want to go back to the foundation of WellBridge Surgical, because you chose to open in Zionsville, where we just had the physicians from Valiant Primary Care share. And I'm just wondering if you could tell us not only about the foundation of WellBridge Surgical, but also the choice to put roots in Zionsville.
I was one of those physicians who saw kind of the writing on the wall being that the rates that were getting reimbursed by the insurance companies, Medicare, all that sort of thing, the independent practices, because I was in an independent practice, being bought up by the hospital systems. There's 4 big hospital systems in the Indianapolis area. And that was something that was pretty disconcerting to myself and my anesthesia partners in the large anesthesia group I was with. 4 years ago, we left the hospital. Back when I would see these patients and they'd say, is this going to be, are you in network? How much is this going to cost? Is the surgeon in network? All that sort of thing about, they really have genuine concern about not only their physical health, that obviously with having the surgery, but their financial health. I really felt that I had been missing something along the line. So that, realizing that need that these patients needed an outlet or needed an option, and really thinking that where we're at as far as physician-wise within the reimbursement culture that you mentioned is going to go downhill rather than uphill for us. Just wanted to challenge myself to create something that would be an option for folks to be able to get to the operating room in a more efficient manner. I grew up in Indiana, grew up about 12 minutes away from where the surgery center is right now. And so we kind of fell into saying that. I kind of grew up around here, went to Purdue University, IU School of Medicine. So I've been around here. So it wasn't so much a choice to do it here. We didn't do research or anything. Although if we had you're probably familiar with the RAND studies. And when we're doing our pricing on this stuff, like before we opened, making our pricing, looking to see what kind of environment we're in Indiana, we realized that the RAND study, I think at that point it was maybe we're the second highest cost for facilities and third lowest reimbursement for surgeons. And so when you have that just disparity and that delta, that incorrect reimbursement percentage, it really made sense for what we do. And what we do is we try to get the best surgeons around that I know and reimburse them more for the procedure, because we control the bundle, and reimburse them more, and then are able to lower the facility costs significantly. And so it just kind of fell into it being a good environment for that.
And what year is this now that you will be open?
So we're just a little over 3 years. So December 2nd, 2021 was our first procedure. And it's kind of crazy because our first week we had one surgery. Our second week we had two surgeries, and then now we're doing over 100 every month. And it's kind of surprising. I looked back the other day to see how many surgeries we did in January of 2022, and it's just amazing how many more we're doing now. And so hopefully it keeps growing like that.
Absolutely. So I think about, as you shared there, it's one thing to recognize that there are problems with the healthcare system, with reimbursements, with the way that patients are asking about, is it going to get covered, rather than focusing on what's my post-surgical plan for rehab and whatnot. But when you think about Dr. Inman, who went to Purdue, went to IU med school, was noticing these things, versus Dr. Inman, who said, I'm actually going to change the way that healthcare is delivered surgically in my area that I grew up in. How did you go then from thinking that this is what's going on is not right, but then actively putting into reality WellBridge Surgical?
I think it's tough because I think, physicians by nature, and one of the reasons I went to med school is kind of you kind of had your path lined out for you, right? You were going to go to med school, you're going to go to residency, you're going to make a decent living, and it's kind of the opposite of entrepreneurship, which I kind of fell into later. But I guess I had that in me. It's the desire to do something different like this. But I tell some people, I went to 4 years of high school, 4 years of college, 4 years of med school, 4 years of residency. After about 5 or 6 years maybe of practicing, I was kind of okay. Well, what's the next step? I'm used to steps and coming every few years, and what is that? And I guess I think personally, I kind of got lucky with one of the other co-founders, my partner, Jeff Williams. He is a serial business owner. So he's done it before, able to kind of help me along with that, saying, hey, this is kind of how it would look. And then we wouldn't be here if it wasn't for Dr. Smith, because it's really funny. At the same time that I had seen an interview with Dr. Smith back in 2017, literally that same week, Jeff Williams, one of the other co-founders, he had seen it like earlier that week on something else, maybe the same one, but we talked about it. Called Dr. Smith, talked to him on the phone like later that week, and then actually went down there and met him. And he was just so helpful, and just he'll do anything to kind of further the free market medical cause, as you well know. And so just had a lot of kind of lucky connections to get there.
Stay with us. We'll be right back. Are you looking for the latest medical guidelines and research without the hefty price tag? Meet Open Evidence, the free alternative to UpToDate that keeps you informed with real-time updates on medical guidelines, research, and best practices. And here's one of my favorite game changers about Open Evidence. It will notify you when new guidelines affect the question you've already researched. No more outdated info, just smarter, faster, and always current. Join thousands of medical professionals choosing Open Evidence for free. Try it today by checking out the link in the show notes. Open Evidence AI. Stay informed, stay ahead.
That's fantastic. And thinking about that, your comment of you fell into entrepreneurship later on, and yes, your partner Jeff was definitely well versed in serial business ownership, the ins and outs of running a business. But when it comes to, you guys created something where there was nothing. And yes, there was the Surgical Center of Oklahoma. Dr. Smith opened in 1997. So there's years of that this model is proven to work. And clearly you've seen that with your own numbers. But I'm wondering, when you extrapolated, hey, not only are we hearing information from Dr. Smith, but also we're in Indiana. This is where you grew up. How could we do things personal to Indiana, whether it be similar or different, because it's a different state than Oklahoma? So I'd love if you could talk to us about how you guys not only took the lessons learned and the guidance and expertise from Dr. Smith, but also how did you go beyond that to make WellBridge unique?
The disparity between how much the facility gets reimbursed here versus the surgeon, that really just fell into what Dr. Smith's model already was. And so didn't really want to change that. I've been with two different hospital systems, and in residency, know most of the surgeons on the north side of Indianapolis. At least I did a few years ago. Usually the ones that I don't know now are the ones that have come out after me. And so what was really cool was I could go to these folks, go to these surgeons and talk to them, the independent ones as well. We only have one or two non-independent ones that work with us because the hospital systems don't take too kindly to that. And so it's been really cool to help the independent surgery groups that I've grown to know around here in the last 15, 17 years, to help them. So every place is going to have a little bit different mix of the independent docs. And so I enjoy helping those gain market share. That's one of our one of our kind of selling points to them is we want you to gain market share. There's going to be people coming from around, and we'll help you out in that manner and want to keep you independent. One thing that is, I think, a little bit different here is that we have a lot more high deductible plans. And so the crux of what we do is we zero tier, meaning that if you are with, say, one of the companies that we work with and we're built into the plan, well, you come here and it's $0 out of pocket to get your gallbladder out versus your deductible and co-insurance was maybe $3,000 somewhere else. And so that's really how you drive the volume. And we learned that from one of the TPAs that Dr. Smith worked with. So we've had to come up with several different kind of avenues up here to get around the high deductible first dollar amount. And so that meaning that the IRS says that the first dollar amount has to come from the patient. And so working around that's been a little bit different. We just kind of started, we didn't know any of the TPAs. We didn't know any of the brokers, and we just started talking to people. And one thing that we've done differently than Oklahoma is we actually are in network with one of the big payers. And so we have an agreement with them that they pay the same amount as everybody else does. And so whenever we talk to somebody new, like a new TPA or a new broker, or whatever, it's kind of blows their mind to say, they'll ask, well, what's the cash price? What's this price? Everybody's the same price. Every single person, whether you're off the street, whether you're United Healthcare, whether you are with a smaller TPA, direct contract, everybody's the same price. That's one of our tenets. We feel very strongly about that. But to be in network, I think what's very different about what we do versus everybody else that I know of is we are in network with a couple networks to try to reach as many self-funded employers as we can.
When we're at the table creating the future of healthcare, opening WellBridge Surgical, opening independent DPCs, I think this is where I would love to go into this. How did you do it? Question, because so many people hear insurance and they immediately just shut down. What I'm hearing from you, though, is that you stood at the table to say, you're going to pay the same price as everybody else because this is how we do it at WellBridge Surgical. And that was acceptable to them. And so I'm just wondering, do you worry about being threatened with United Healthcare pulling strings to try to change that story in the future? And how do you address those thoughts from other people in our community who are like, oh, we just heard United. Oh, heck no.
Yeah, I think that, and I was pretty skeptical early on with, I didn't even know what the medical loss ratio was before we started thinking about this in 2017 and realizing that, well, hey, maybe like the magical insurance tree that everybody gets their medical care at, right? The insurance is paying for it, quote unquote, even though 70% of folks that have their insurance through their employer here, it's really not insurance. Those companies are accessing a discounted rate from a charge master, but it's all their money. They're just an aggregate of self-payers, and that's all it is in reality. So I always thought that the insurance companies would want to pay less, right? That would make sense to me. And then I read some stuff that, well, with the medical loss ratio, well, maybe they don't want to pay less. Maybe they want to pay more because 20% of $1 million is more than 20% of $500,000. And so I was skeptical. I thought that was probably the case. Yet we just have a family. My wife's family has a connection that knew one of the executives of the kind of the regional area, Indiana area, United Healthcare network. And so we got an introduction to them, and they were new to the area and were kind of sticker shocked by the pricing. And they came from out west. And so realizing that it's crazy. She's like, we could ship people out to Las Vegas and have them come back, and it would cost less for a colonoscopy. And that's not even a high dollar procedure. And so you do run into people who genuinely care about the cost of care. And I tease that out from what their job description is too, right? Like maybe you care about it, but like you're trying to hit these quotas and you need to do this for your boss or for a raise or whatever. But these folks that we talked to in United Healthcare cared about that. They saw that there was a need for it, and within United Healthcare, it worked for what they were trying to do. At least these folks were trying to do. And so we believed them at first, and it turns out that they followed through and wanted to do what we wanted to do, and it's been helpful. And I don't think you're going to go in if these people don't have open minds within these networks or these carriers, these insurers. If they don't, you're not going to change it. And so I think we kind of lucked into that group and that niche within the company that wanted to do that. And so it's been really helpful in that. You've got the fully insured folks that they're not through their employer, but they just have a fully funded plan where they do pay a premium, and then they pay that, and then in that case, it is kind of like the insurance tree. You're paying a premium, and then the insurance pays for it. But then those folks can pay less deductible, less co-insurance here at WellBridge, and we can kind of increase the access of care to those folks. But with the self-funded employers, it's been helpful to be in network with United Healthcare in that there's a fair amount of market share that United Healthcare has that is self-funded. And so they're basically administrative services only with United Healthcare /UMR. And it makes it easier to be able to work with those companies, because one of the big companies we have in Kokomo, they're with UMR, and we've been able to save them hundreds of thousands of dollars for the last couple of years. And so they're a big payer, and it's helpful to be able to work with those folks. So if otherwise, you kind of have to get them away from the BUCAs. And that's not an easy task when you're going and talking to HR and the CFOs and the CEOs. It's a kind of a comfortable, cozy nest that they're used to. They complain about it, but they're used to it. And it's hard to get somebody to change because it is a risk. I mean, any change is a risk, and nobody wants to lose their job making a bad decision on benefits. And so it increases the amount of folks that we can talk to, the folks that we have access to be able to help. And so it's been super helpful. We're working on other insurers to be able to do that in Indiana as well, because we want to make it as easy as possible for everybody to be able to access the WellBridge prices and the WellBridge surgeons. And so we're going to continue to try to get in network with more folks too.
Even in the beginning of the interview, you mentioned how you're getting higher reimbursement rates for the surgeons who are operating at WellBridge compared to what they would be getting in their typical fee-for-service practices. Here, I want to ask about with you and Jeff coming together, bringing insurance into the fold. I'm just wondering about what is the percentage of your procedures that are self-insured, self-pay versus a larger insurance plan like United, and have you guys come up with scenarios if the insurance, if the BUCA type plans start trying to negotiate your rates down and down and down? Do you have an exit strategy if that were to ever happen?
To answer the first question, well, I guess it's tough because there's a lot of different kind of quote unquote self-pay. You have the Christian healthcare ministries, you have just different concierge services, you have straight cash pays. I'd say 70% are from the self-funded insurers, self-funded employers. So they're funding it out of their own pocket through a TPA. Although sometimes the TPA is UMR, which is with United Healthcare. And so That would count. Those UMR ones that are kind of a buca payer, they are still within that self-funded employer percentage. Out of the self-funded employers, I would say that United Healthcare, because that's really the main one that we're with, is maybe half of what we work with. We work with a lot of smaller TPAs, maybe 40%, something like that. We work with a lot of smaller TPAs, but the biggest TPA that we work with is UMR. And then if they try to crash our rates, our exit strategy would be we would cancel the contract with them. And then so we're not going to go lower for them. We can't really go lower for them because when you're in network with one of those bigger payers, there's lots of, you have to, and this is why Dr. Smith doesn't want to do this. And I don't really want to, but to be able to have access, like I said, to be able to cast your net a bit wider, we made the decision to do it. But you have to deviate somewhat from the model of, and I'll say this like Dr. Smith said it. At first, he's like, "No, I don't want to mess with that. That's insurance, and I don't like it." He's like, we do everything cash pay. We want it to be upfront cash pay, and we can make this taste like, smell like, look like a cash payer, and everything's paid up front. We have the patient pay the deductible and the coinsurance up front because that's typically the hardest part to collect anyway. But we still go through the regular process of getting the insurer, UHC or UMR, to pay, usually paid within 6 weeks or so. So you do have to deviate somewhat, but we've found it to be worth it so far. Because of that, you're deviating somewhat. Your AR is coming in a little bit slower, then you can't give them better rates. If anything, it'd be higher rates. But as far as like if they said that they didn't want to do that, I mean, what we would do is we would go talk to the employer because the employers are very happy with what's happened. Like I said, that one in Haynes International up in Kokomo, Indiana, about an hour away, 50 minutes or 60 minutes away. They're very happy with what we've done. Like I said, we've been able to save them hundreds of thousands of dollars, and not just savings. It's a concierge service. We've got patient navigators that basically handhold them through this process of surgery, which is not fun usually. And so they make it a better experience, and it costs a lot less. And so one of the strategies would be we'll go to talk to the employers and have them put pressure on the payer. And we haven't had to do that yet, but just thinking out loud, that's probably the way we'd go because we know that we offer a good service, a good benefit to that employer health plan.
And just because the idea of non-competes is really upsetting for a lot of people when it comes to they want to open up a DPC in a lot of cases that have been talked about on the podcast, and they can't because of non-compete issues. Mm-hmm. You mentioned how there are some hospitals, clearly there's in every community, where they don't like their staff to be helping other people, right? When it comes to concerns about talking to employers, when it comes to having physicians come on board, how do you guys get around the non-compete, whether that be like directly in the verbiage with a United Healthcare type contract so that you can talk to employers separately, as well as hire physicians who are great surgeons? Yeah,
so with the surgeon part, we haven't really found a way to get around that, other than it looks like hopefully there's a bill going through this summer that will be in Indiana will say that physicians can't enter into a non-compete agreement with an employer. Right now, the way it's written, I think it's written for any kind of physician with any kind of employer, which that's good for me. I'd be happy with that because I think most physicians would think, as long as they're not on the administrative side of hospitals, they would think the only proprietary knowledge that I have came from med school and residency, and that has nothing to do with my current employer. And so there's nothing that I should be restricted by them to do. And so I feel pretty strongly about that. For our business model, there are surgeons that we wanted to have credentialed at WellBridge and do procedures, and the CMO of the hospital has said, no, you can't do that. And it is sometimes, well, really most of it is just they look at us as competition and don't want to support that, and just kind of blindly say no. So we haven't really found a way around that, other than there's a couple that have become physician owned and they kind of grandfathered in. That was part of their agreement.
Is there any verbiage in the contracts with these insurance companies like United that does not eliminate the option of you speaking to employers? It just like similar to the physician not being able to work somewhere because of a non-compete. Is there any concern about United saying like, well, this is our employer, you're not able to talk with them if we end our United Healthcare WellBridge contract?
Yeah, I don't believe there's anything like that in there. So we talk to the employers very often, and we'll give them either like monthly, quarterly, yearly savings analyses of that you had this many procedures done at WellBridge. This is what you saved on average versus market price. So there's nothing that says that we can't do that.
Now, when it comes to the actual patients, you mentioned how in week 1 you did 1 surgery, in week 2 you did 2 surgeries, and then that's just blown up from there. But who comes to see you, especially from the DPC community? Because this is sort of a loaded question. I've had multiple people say like, "Oh my gosh, you're talking with Dr. Inman today." Can you give us some examples of how it would work where a DPC physician anywhere in the nation would make contact with WellBridge, and how would that work with getting the patient evaluated, scheduled, and their surgery bundled for them?
Yeah, so surgery bundled, we have hundreds of surgeries that are already bundled, and we have prices for them. Most of the common ones. Every once in a while, really still at least every week, I've got to go on basically we just have a pricing calculator Excel sheet that I look at to see what our bundle for that would be. But yeah, we work with a lot of different direct primary care docs around here, and then you get a fair amount from some of them of referrals. And so we work pretty well with them. Our navigation team works pretty well with them. When we had only like a couple patients a month or whatever, I was basically the navigator. And it's still fun to do that sometimes. Like I'll still do it sometimes if we get an email, because it's cool to be able to help people. It's nice. And so we've got a navigation team right now of a couple of really three different navigators that will help out, and they will take in if a direct primary care doc comes to us, what we really like to do is just show them around and have them come in for a tour and say, hey, this is where, if you send your patients here, this is what it looks like. Because I've been to a lot of different surgery centers, and this is a newer facility. It's just more welcoming. It doesn't feel sterile and hospital-y. And so we like to show the direct primary care doc who's going to refer us, show them around, and they will meet Rebecca, who will probably be the one who would be taking in the surgery scheduling sheet or the referral sheet. So there's a referral sheet that we'd get from the direct primary care doc. We would reach out to the patient and then let the direct primary care doc say, hey, this patient has a appointment with Dr. Johnson ENT for their kids' ear tubes. They already will have known what it costs because we'll tell them about that right up front. Most often, these are self-pay folks that are referred from the direct primary care doc. They see a little bit higher percentage of those, as you probably know. And we just have communication between the navigator and the direct primary care doc's office that says, this is what happened at the appointment with the surgeon, and they're going to have surgery this day, and then send the op note to the doctor, and just kind of keep the navigator and the offices in pretty good communication. And so just keep them up to date on anything.
If a doctor who has a patient who's a little bit farther away has an update, if they wanted to send a picture with like a video otoscope or something, how does that work? If there's like, hey, they're on the schedule for 2 weeks from now or something, but does this look more concerning that we need to push them up? Something like that.
Yeah, I mean that would just go through. Still would go through the navigator, and then even sometimes I'm called in because I've got all the surgeons on my phone, and I just call them up and talk to them and send a picture if need be. That particular situation hasn't. I don't know if it has happened. Maybe a couple times. It's so easy to be able to just get that figured out within a couple hours, depending on where the surgeon is in their workday.
Fantastic. And can you talk to us about any guidance that you give to direct primary care physicians who do refer their patients to you? Because even with patients who are used to paying cash for their primary care, sometimes they'll think about surgery as just not an option to do through cash pay. And I wonder if you have any guidance for the DPC doctor who wants to encourage their patient to think out of the box and to think cash-based surgery. What are some big takeaways or buzzwords that you find are really effective in the DPC doctor talking to their patient about, look, cash pay option is an option in the surgical world as well. Here are some things that can help you understand that patient of mine.
Yeah, we say it's an average of 40 to 60%. So it's an average of 50% less than the hospital prices. But sometimes, like the other day, we had one of the brokers that I've known actually since high school. He's one of the brokers around here who works with some of the employers we work with. He had heard about a procedure that was going to be, I think, $13,000, and ours is $5,000 or $4,000 for the same exact CPT code. And so sometimes I think you have to stress how much less it can be. In one of the other hospital systems around, like it's been like a finger fracture was 22,000 versus 4,500 for us. And so sometimes there's that much of a difference. And if you look at what you would pay through your deductible and coinsurance, a lot of times, and Dr. Keith probably said this too, I know he said it to me, so a lot of times that's like what you would pay at WellBridge or Surgery Center, Oklahoma, wherever it is, it's going to be less than your deductible plus coinsurance. We tell everybody that we have utilized care credit. It's basically one of the programs is 0% for 6 months. So if you pay by 6 months, then it's no interest, which is helpful to a lot of people. A lot of people have to do that because say it's going to cost $4,000. Not a ton of people have $4,000 sitting around to be able to, even no matter what their deductible is, they don't have that. And then, and same for the self-pay folks. So the care credit, realizing that it could be less than most people's deductible. It doesn't have to be that much. Don't be scared of it.
What is your time to surgery typically for WellBridge? And if that differs depending on types of surgery, can you speak to the time that a patient expects to wait? Because in fee for service, it's probably way longer.
Yeah, I think it is. And so that's one of the advantages we have is to be able to get people in a lot faster. For instance, I think I talked to the broker that I talked to about that kiddo who had the arm issue that it's not going to cost 13,000, it's going to cost 4,000. They were scheduled for surgery, I think on April 11th, and we were able to get the patient in. We get the patient seen by somebody else and scheduled for surgery like a week before that. So we can almost always beat it. And that's not even, I mean, like if there's a good reason to, it's going to be better medically, we can get it in even faster than that. So we have two operating rooms that were fully functional up until this month. We opened a third one. It's not because we're running two rooms from 6 a.m. to 6 p.m. Part of it is because of what you said. We don't want to just be quote unquote cheaper. We want to be a better experience. And part of that better experience is getting people in sooner. And so to open up that third operating room, now we're able to keep with what we had when we were not busy at all. When we're like, hey, you want to have surgery? Oh, you do it later today? We're not doing anything. It's not like that anymore, but we want to be able to be flexible, that we can get people in faster. It's always been an advantage of ours, and we want to keep it that way. So it is different with different procedures, but in general, we can make it happen. And everybody on our team, especially really everybody, we take it pretty personally, and we've all come from the hospitals, other surgery centers. We believe in what we're doing here. And like I said, it is cool to make a difference and pull some strings, make things work, and get people in when they need to be in. And so it's just smaller in this case is better for that.
And it's very local. Like that's at the end of the day, why our patients really love DPCs, accessing care that is driven by the local needs and having somebody who is locally accessible. So I think you guys are definitely achieving that. When it comes to the surgeons who you've had come into the fold at WellBridge, I'm wondering, what does that look like in terms of the discussion for getting really good surgeons who really also understand and want to operate under the mission of WellBridge?
One of our selling points is, hey, we will pay more than Anthem or United Healthcare will. And that's helpful. We'll increase market share, but people like physicians, for the most part, we all know there's outliers, but for the most part, like we went into this to help people. And at some point along the way, you kind of forget that. So to be able to do something like this, I really believe, maybe I'm being naive, but I really believe that a lot of the surgeons feel good, or I know that they do because they tell me, feel good about this company always has the best people, and I love helping them. It's really cool to be able to facilitate those surgeons being able to do that with them. And I feel like that's also probably part of the reason why we can get people in earlier. They'll jump through a couple of hoops, the surgeons will, because people do want to help others. I mean, most people do, to help others, and are willing to kind of do the extra thing if it's the right thing. And I think that we have that group here. And probably some of that is the folks that we've selected, because I can probably think of some that I've worked in the past that wouldn't really care, but we haven't chosen to work with them. So it's good all around. It's a good group.
Fantastic. And then after a surgery is performed, what is your guys' follow-up, whether it be with the DPC doctor to give them an update and help them formulate a plan for aftercare, or if it's directly with the patient?
Yeah, so everybody gets contacted the next day, or I guess if it's a Friday, I think it'd be a Monday. The next working day, business day, every patient will, from our staff, to say, we have them fill out a survey, anything, how was your experience? The nurses will write that stuff down and we'll put them up on our board in the break room, the good ones at least. But really, like they're pretty much all good, which is nice. So that's the follow up with the patient. And then the patient will follow up as far as postoperative visit, like say gallbladder, you'll see the patient, the surgeon will see the patient generally in that surgeon's office. And so it's not like the preoperative visits aren't at WellBridge, the postoperative visits aren't at WellBridge, they're at that independent surgeon's office. And the communication with the direct primary care doc that's with our navigator, and then they're sent the information. Usually, it's crazy as it sounds, I think it's usually still fax with the operative note or the pathology diagnosis on a colonoscopy with polypectomy.
I laugh at that because yes, in 2025, when we're recording this, fax is still a thing. I have to tell my non-medical family that, and they're like, "What you mean, like a fax?" And I'm like, "Yeah, like a fax."
Yeah, it's just medicine, I think. I don't think it's anything else. Yeah.
For the listener, if you do go to WellBridge, it's wellbridgesurgical.com, their website, you can see at the very bottom of pricing the average market price comparison. But just for the listeners who are like, wow, I'm driving, I'm mowing the lawn, what are some of those prices that you love saying, like, no, look at this price that we offer?
Yeah, I mean, I think a very common one that everybody, and I need to get mine done. I'm 45 now, so it's a colonoscopy, and so that's just one that everybody knows about. They should know about. And so our price is $2,310, so $2,310, and the price around here on average, I believe is, and it's really hard to get averages because people don't want to give that up, but it's around $5,000 because we've done a lot of digging as far as looking at different savings analyses. That's one. Gallbladders typically cost $10,000 more, so our price is a little bit under $10,000. The average cost is more. It is about $10,000 more than that. Any higher dollar procedures, you give the higher dollar savings. But there's an example of just down the street, you can get a carpal tunnel and it costs $11,000, and ours is I think $4,150 or something like that. Breast reduction. One time I saw a hospital literally about 4 miles that way. It was $49,000 that was reimbursed for breast reduction, bilateral breast reduction. Our price is less than 15. I forget exactly what it is, but it's just absolutely crazy to pay those prices. And I hope nobody has to going forward. And we're just the start. Really, we're really just the start of people being able to make that distinction. The hospitals don't want you to be able to make that. They don't want them to know how much things cost. But I hope we do like what they do in Oklahoma City, or what they have done there. Keith started it. Keith and Steve and them, and they started it. And what we want to see is what's happened in Oklahoma City is now the hospitals are doing it. I think the cost of care is less there because of them. We're not scared of that. We want that to happen.
Well, thank you again. This has been fantastic. I hope it helps people out there understand even more about the options when it comes to cash pay surgery.
Yeah, I want everybody around to know that there's other options. I want other places to start. I want to grow WellBridge so that we can help even more people. So I appreciate it. What I want, and I know you do too, is physicians, whether it's anesthesia, surgery, or primary care, to be able to realize that it doesn't have to be the way that it seems like it's going. You can be an entrepreneur, and just like you have, just like a lot of the folks you've talked to have, it's worth it for sure.
Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory, and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the daily, check out dpcnews.com. Until next week, this is Marielle Conception.